This is a podcast about our lived experience, which unfortunately includes infant death and subsequent mental health struggles. Please take good care of yourself and only listen if this content feels safe for you right now. We'll still be here when you're ready.
Hi, I'm Judith.
And I'm Alina. We are internet friends turned real-life friends who both experienced the tragic loss of our sons to sudden infant death syndrome in winter of 2021.
In the year after Aiden died, my husband and I both became unemployed. My parents divorced, and we had to move 5 times for various reasons.
And as for me, just a few weeks before my son Quinn died, my then husband had come out to me as a transgender woman and were subsequently divorcing.
It's been a lot.
It's been a lot.
But as long as we're living, we will love our sons deeply and work to make sure that we live a life that makes them proud.
Welcome to As Long As I'm Living podcast.
We're so glad you're here.
Hi, everybody. We have such a special episode for you today. We could not be more excited about this. Am I right, Judith? About this episode with Dr. Goldstein. So before we get started, I want to just let you know we have decided to split this conversation with Dr. Goldstein of the Roberts program into 2 parts. So this episode today is all of our questions that we asked him related to SIDS and infant death. And then next Monday, will be a follow-up episode continuing the conversation about grief, parental grief specifically. And there's a lot of good stuff in there. Also, next week's episode is the one where we asked the remainder of the questions from the listeners. So if you don't hear us ask your question in this episode, check in on the next one. We did not get to all the questions, but we asked him a lot of things, and he's just a wealth of knowledge. So,
Alina, a lot of times in this episode, Dr. Goldstein talks about safe sleep practices. Should we just quickly go over what safe sleep practices look like, so we all are on the same page with what they are?
Okay. Yeah. So one thing we did not really ask Dr. Goldstein is, what is SIDS, and how do you prevent it?
Well, he went into a deeper dive. We did ask how do you prevent it. He went into a deep dive of it, but I think that it was an assumption that we all know.
Yeah. Or we could put it at the end.
And we could be okay. Yeah, I think because I don't want people to think it's like us, talking about this.
I completely agree. I think I think we should
put it at the end.
Without further ado, we will listen to Dr. Goldstein talk.
Hey, is this your first time being on a podcast? Because if it is, we're so honored.
I don't know how honored you should feel, but it is my first time doing a podcast.
Oh, we feel very, very honored. When Alina and I started this podcast, we wrote a list of our dream interviewers. You know what I mean? Like Oprah, Sheryl Sandberg, the interviews we were dreaming of. Megan Devine, and your name was on the list. And so far, we haven't heard back from Oprah.
So I could be the near great.
You might be the only one we're going to get, so we're really excited about it.
Can I ask one question of myself?
Okay. Of course.
Do you want to not mention, or do you want to mention Quinn and Aiden?
Oh, we mentioned them.
Oh, we talk about them all the time.
Your viewers
we would love to mention them.
Okay. All right.
That's so sweet to ask. What a nice thing to ask.
Thank you for asking. So I'll just give a quick introduction to all of our listeners that today we have, as we like to say, the man, the myth, the legend, Dr. Goldstein, who's rolled his eyes. Is the director of the Roberts program and studies SIDS and also studies grieving parents. So our first question to you is how you got into this field, because it's a niche. And I think for us as parents, it just feels like such a relief to have somebody out there like you who cares and who is working to find the solutions to the problems where we have no idea how to even start. So I'm curious how you ended up studying SIDS and how you ended up studying grieving parents.
So I'm going to make up the answer because, like a lot of important things in life, they just sort of happen. But before I went into medicine, I volunteered in an emergency room. And probably the most impactful experience I had was one morning when a baby came in. I first of all, I had never really thought about babies dying. It was a poor Black family who were the parents, and the cop was really hostile behind them. And I'd never seen that kind of a thing happen based upon every idea I had of respect for the dead and for the grieving. And I don't know, I came away with it just very attuned to it as an issue. It's not really taught. It's, people talk about prevention. They don't really talk about it. But I never said no to any project or anything that anybody had about SIDS from that time on. So that was through my career. I went into palliative care really as an outgrowth of my work in general practice. I was a general pediatrician for 20 years. And in my practice, I took sicker kids into the practice, and some of them died. And I found that work really meaningful. But I also was, I don't want to fetishize it, but I have to say, the challenge of picking yourself up after your child dies is extraordinary. And when you have a trusting relationship, like I had with some of those families, it feels important, and it feels like unknown but extraordinary things are happening, that there's a completely uncharted course, that the stakes are really high. And I just never felt intimidated by that. I wanted to be there. So those two things came together when I started at Dana-Farber on this team called the Pediatric Advanced Care Team, the PAC team. Now, I think about 12 years ago. And the world's leading researcher on SIDS had known about me because I was the head of the Massachusetts Center for SIDS. And she came to my office, and she knocked on the door, and she said to me one day, she said, "Do you want to do something?" Which was extremely generous. But it was a new job. So I said, "Let me think about it." And I came back to her and I said, I only have one requirement, and that is, if we do anything, that we build this around parents. That I'm all for your research. I think it's really important. I think that there's a lot that's neglected here by science, but I also feel that the parents are just discarded and suspected. And if I'm going to ramp up and do something meaningful in this arena, it's because I think we know enough now that we can start to offer alternatives that are different than what's been offered for the last, 25 years, 30 years. Mm-hmm. And so that's my story into it. I think we didn't know what the program would be like. We knew that we wanted to inch our way towards something that was closer to a clinical service. That's, people always say, well, who's your patient? Your patient has perished, really.
I do think of you as Quinn's doctor.
I think of myself as the doctor for the kids in the program, yeah, and as their advocate. And, sometimes that means that I have to, on behalf of the child, say things that are difficult for the parents to hear, although every part of me wants them to feel better about what happened. But I feel that, just what you're saying, I feel like I'm the kids' doctors, and my role is to settle accounts as much as we can for what happened.
Mm-hmm. I think that is so important, because after your child dies, especially of something like SIDS, everybody else just kind of shrugs a shoulder. Like my son's pediatrician just said, it just happens. It just happens. And that is not an answer. That's not an answer that satisfies someone like myself or just any parent, I think. And I think, to me, it shows the strength to be able to say, I'm not going to just roll over and let this be something that happens. I want to get to the bottom of this to the best of my abilities. And I don't see, my sister is a pediatrician, and I asked her in her practice, has anyone ever had a SIDS case? And she said just one. So I guess if, and in her, not just her, I'm saying in her entire practice. So I guess if you only see it once in your career.
But let's, but if you maybe that's why. It just a little bit. So let's think about training pediatricians and family doctors. And, So the shocking fact is that 1 out of 1,000 babies that are born in the United States die from SIDS. I mean, there's nothing. It's if you add to SIDS other unexplained deaths in children over the age of the year, that's over 10% of child mortality in the United States, and somehow we turn away from it. We don't reckon with it. I mean, the follow-up question is, how many kids with cystic fibrosis have died in your sister's practice? How many kids with cancer have died? And there is this aspect to it where it's been disenfranchised. It's been called a sleep mistake, where parents are largely responsible for that. And maybe that's the case in a minority of cases, but I think it's a much more complicated story from that. And regardless of what it is, how about just like the basic calling of a clinician to respond to a young family and their needs? So that feels all clear to me as something that we should just be doing better.
I read that SIDS is the #1 cause for infant death
after a month of age. So that's called the statistical term is post-neonatal mortality. And that's not just true in, the Wild West of the United States with all its heterogeneity. It's true across all the first world economies. And where it's not true, there's either, now I'm talking about less developed countries, it's either because there's so much infectious death, or it's because they don't do autopsies to look, because part of the definition is that it's the classic idea here. The classic problem is that these babies are put to sleep well, and for really no clear reason, they die. And it becomes SIDS when people have made a legitimate effort to look. So part of the definition of SIDS is these children deserve an autopsy. They deserve an investigation of the circumstances under which they died. Their family histories need to be reviewed as well.
Am I right in saying that it's a diagnosis of exclusion, where it's like they didn't find anything else and thus it's SIDS?
Yeah, that's right. And just because the terminology is so hard, not just here, but everywhere in the world, there's a basic skepticism of that there can be something where you don't find anything. And so some medical examiners will refuse to use the word SIDS, and they'll say cause of death is undetermined. Others will say, well, we know that sleep position matters so much, and if there are any risk factors for sleep in the child's environment during the sleep period, we'll call that accidental suffocation. And sometimes that's the case, but it's worth asking whether just how involved that was in the process. But those three categories together now need to be tracked by themselves, and that's called SUID, or in Europe SUDI. And SIDS is just under 40% of that, and the rest are these sort of diagnostic substitutions.
Mm-hmm. We actually also had a couple of listeners ask about SUPC.
Are those related? Like, are these all in the same category? Is that different?
So in our research, it's SUDP, sudden unexplained death in the pediatric age range. I think that's what you're talking about, unless you're talking about
no, it was
death.
Sudden unexpected postnatal collapse. So when the baby's right. Like a couple days old.
So the original conferences, the original medical conferences, which occurred in the 60s, defined SIDS not based on any age criteria, but looked at this phenomenon of children who seemed well and died during sleep. Mm-hmm. And at the time, the observation was how striking it is that for the first month of life, you don't really see SIDS very much.
Mm-hmm.
And then you see it very concentrated between 2 to 4 to 6 months, and then it very much tails off, but it continues, the tail extends farther. And I think it's a mistake, but one of the efforts of people to understand what's going on here has been to parse these groups into smaller and smaller groups. So SIDS became limited to children under the age of 1 when back to sleep became successful. And people said, well, if we're talking about a 15-month-old, does it really matter what position they're placed to sleep? Because, it shouldn't matter. Developmentally, they should have outgrown it. And similarly, now we have all this big data, and we can start going into this immediate postnatal period. There's concern about babies that die in the hospital in the hours after delivery, and then there are these babies that die very early on. We don't entirely have a framing for it. I mean, in some ways, in some ways, they're not strictly speaking, a part of SIDS, but it's an area of great interest. So there's a guy here in Boston who's interested in just this area. There's a group in Seattle who focuses just on this very early stuff.
Can you tell me their names so I can let them know? Those two couple of listeners.
Yeah, Joel Bass,
mm-hmm.
and then Nina Ramirez leads a group that collaborates with Microsoft in Seattle, and they do big data analyses, and they've had some papers that they've looked at these early deaths. But our program is SUDP also. I think I'm not sure that your abbreviations for them are right, but SUDP is unexpected death in pediatrics. And the reason for that is that we do think that it's a continuum. It's a continuum that might extend to stillbirths and to prematurity and through SIDS and into sudden unexplained death in childhood, and then into early cardiac deaths, as well as sudden unexplained death in epilepsy. And if you look at SIDS and you look at SUDC and you look at, if a person has epilepsy, they have a over 20-fold increased chance of dying for no provoking reason in their sleep. And they're all found prone. And the kids that die from SUDC are largely found prone. And the kids with SIDS are largely found prone. And so it raises all sorts of questions for people that are trying to research what the mechanism of death is, what they might have in common.
Mm-hmm.
And we actually
prone being face down for our listeners, right? Just in case you don't know that. Mm-hmm.
But I know you explained this to me when I first came to you. In Alina and in Quinn and Aiden's case, when they were found face up, does that remove some of the theories of what it could be?
No, well, so we think it's a hodgepodge. We use the word heterogeneous combination of causes. And we think that there are a lot of diseases that we just haven't figured out yet. And one of the reasons that this clustering of diseases hasn't been figured out is that these are mandated autopsies that go to medical examiner systems. They're very under-resourced. The people that do the autopsies may not have very much training in pediatric autopsies, particularly infant autopsies. And they're kind of sequestered away from all the new advances that you'd see in an academic medical center. So we think that applying current techniques just discovers all these things that have been there all along. That's really the strength of our program. I mean, we find in neuropathology that there's overlap of signs in the brain of epilepsy or epilepsy-related changes. We found that there are real dramatic differences in serotonin in the brain stems, and that impairs the response to otherwise modest threats. So many people think that SIDS is suffocation, and the prevailing theory is that it's not simply suffocation, that a normal child sleeping in the prone position or with some covers that go over their face, if that's part of the mechanism of death, wouldn't go into a lethal cascade, that there has to be something else that's going on. And that something else is really what we try to discover. Sometimes.
So just to go into the serotonin thing, because I'm not sure everyone 100% knows what that means. From my understanding, it means that they fall into some sort of like higher level of serotonin means what they fall into like a deeper sleep and they just can't come out. Is that what it means?
They have deficiencies in certain parts of their brainstem. And the parts in their brainstem are involved in something called autoresuscitation. So let me start by describing what you would normally expect to see. If a baby without these serotonin differences gets in a situation where their oxygen dips or their carbon dioxide increases, number one, they arouse, right? You wouldn't just lay there. Number two, they have a very typical response to the hypoxia. They start to gasp, and those gasps are driven from the brainstem. And those gasps are coupled to a heart rate response. So they start to have these profound gasps, the heart rate comes up, the kids get alert, they arch, they turn, they free the obstruction, and they survive. That's normal autoresuscitation. And that's what we would expect to see. But the picture that we have from SIDS, and so about 40% in a number of data sets have deficiencies in serotonin in their brainstem. What we think happens there is that they just stay asleep. It's a very quiet death. And they may have these gasping spells, but it doesn't, it's not accompanied by arousal or an increased heart rate. And they just go deeper and deeper into a hypoxic coma and die. Now, one of the difficulties is, because it occurs during sleep, they're really rarely observed. So we don't entirely know. It's sort of a model that makes sense, but we've put them into animal models. So a mouse has the same kind of autoresuscitation that I was just describing. And if you take a mouse and you knock down their serotonin, they will do just what we're describing in the SIDS babies.
Which brings us to, I think, the number one question we got in 25 million different forms, which is, well, what are some of the things that you can do to prevent something like that happening, aside from back to sleep, which is the most common one?
Although feel free to tell people that, but
yeah. So I guess that comes in two ways. There's something that you can test. Can you test for serotonin? Like what tests can be done? And then what can parents do to prevent SIDS, in their daily habits?
Yeah.
At home.
There is really no test. Our group is working on some tests, like the low serotonin in the brain seems to be associated with higher serotonin in the bloodstream. And we're trying to see if we can, this is a woman named Robin Haynes, who's here at Boston Children's Hospital. She's trying to see if there's any predictive value in doing as part of the newborn screen, a heel stick on babies to see if you can predict who has susceptibility to at least one part of SIDS. I'll answer in the way that most of the parents who've been through this would answer, which is, if you can do anything to prevent this, you better get on it, because it's the worst thing. You guys have no idea how terrible this is. So pay attention to all that. It's, bumpers aren't that important. A lot of the stuff that we're so obsessed with before the babies are born, all this equipment and all this fluffy stuff and the baby environment, just make it safe. I think.
So what does that look like? So some people, a few questions on that, just to dive deeper on that. So some people say, don't let your baby sleep in a car seat. Some people say, don't let your baby sleep in a swing. Some people don't want to send their kids to daycare because there's some correlation there between daycare and SIDS deaths, something like that. Some people, the bumpers and the stomach sleeping, like there's a number of, Alina said she one time met someone who wanted to have their baby sleep in a hammock. Like, what are the things that are considered dangerous, or I don't know, maybe increased risk instead of dangerous? Maybe that's a better word to use.
Okay. So look, prone sleep, maybe fourfold more likely. A baby that dies from SIDS is much more likely to be found in the prone position, placed in the prone position, and found in the prone position. Sofas and couches are really dangerous places to take kids. Now,
even if they're on their back,
people, you're shifting it, and you want to let your partner sleep, and so you go to the couch, and it's just so much more dangerous. Now, I'm also aware of the fact that I think there's a lot of this that's just not really going to go away simply from sleep position. And so that's why prenatal care is important. That's why not smoking is really important when you're pregnant. And that's also why legitimizing this kind of research, because, one way to look at back to sleep is, wow, across the world, we've all decided to do this, and the SIDS rate is half of what it is. It still exceeds everything else. Mm-hmm. The SIDS rate went down in groups that, we are forever on talking about Black families don't put their babies to sleep in the recommended position in the same way as white families. It went down 50% for them. Germany had no back to sleep campaign. It went down 50% for them. Wow. Other causes of death went down at really parallel rates at the same time. So there's more involved in it. And more than that, if we look at this SUDI category, this combined category of what we used to call SIDS, it hasn't changed for 25 years. It's still the same shocking rate of death. So clearly there must be something more that's going on.
The 3-factor model,
the triple risk theory,
yeah. So that would be like the infant itself has some kind of a vulnerability, either that serotonin and then maybe the position that they're in, or maybe I'll let you explain it. But the 3-factor model, is that something that you guys?
Yeah. So think about a baby who dies in the prone position. We think that most kids would survive that position. In fact, for much of American history in the last century, that was the recommendation, right? Mm-hmm. So you didn't invariably die from being placed in the prone position. We think that there was something else that was involved in it. And the two areas of work are what we call intrinsic vulnerabilities. So that could be serotonin, that could be epilepsy-related genetics, that could be cardiac arrhythmias, it could be brain malformations that affect basic reflexes. It could be a lot of things. So a child in that situation, and especially a child at certain ages, so at 4 months, between 2 and 4 months of age, why is it all happening then? Well, that's a good question, and we don't entirely know the answer, but we do know that when you look at the maturity of brain organization for sleep and how it affects basic functions in a child, that between 2 and 4 months, the sleep states are reorganizing. Mm-hmm. And coincident with that, there's a kind of softer blood pressure control that you see. And so we think that that's kind of a perfect storm in the case of some of these kids. The triple risk is intrinsic vulnerabilities, external threat, and a developmental critical period.
Mm-hmm. That's challenging because it's challenging because as you want your future children to all live, it's like, what are you supposed to do? Like, what are you supposed to do? Because you can't possibly, there are the sleep position is definitely one thing, but if you can't know that your child has the intrinsic vulnerability and you can't keep your baby up or continue waking them up every 2 to 3 hours, for 6 months, to keep the pattern.
Well, look, it's an undiagnosed disease, but there are people that live with undiagnosed, who don't die from them. They live with problems that don't have an explanation yet. And
we just got unlucky in our perfect storm, basically. Like
maybe, but part of this is a really challenging issue for us. So what if I figure out a way to predict who's going to go on to get SIDS, but I don't really know what to do about it? Yeah. Right? What is there's a point where those of us who are working in this area have to recognize that the closer we get to actually figuring out what's going on, in some ways, the more horrible it becomes, right?
Yeah.
Because people start to think about this, the appeal to you just put your baby on your back and they're going to be fine, is that it's nice and simple and everybody feels self-possessed and like they have all the solutions. It's just that the real world tramples on that all the time.
Yeah. It's like a false sense of security. Like we're giving ourselves a false sense of security. And I think when Aiden was alive, I certainly felt that way. I was like, oh, I'm following the back to sleep guidelines. There's nothing in the crib, like I'm doing all the right things. And I don't know if that's even the healthiest message. Like I almost wonder if it's a healthier message to say, like these things happen sometimes because it's an undiagnosed disease, and sometimes you're just at higher risk for certain things. And these are the things that you can do to reduce risk, but there will always be a risk, as opposed to the guidance I got from the pediatrician, which is like, oh, it doesn't happen. Just they didn't say it doesn't happen. They just said you don't have to worry about it because you're putting your baby on its back.
Well, I think I don't
think is a healthy message.
Well, that was a decision that gets made in different ways in different parts of the world. And the decision here was really to not complicate the message so much, because they really wanted people to follow the advice. Mm-hmm. And there are some merits to that. I think it's really hard when people have done everything right and their baby died anyway.
It also does provide some measure of reassurance to me, because I could not have done anything differently. Like, I don't know. I think neither is good. Both of them feel bad.
But almost what I hear Dr. Goldstein saying is that, let's say you did put your baby in a prone position, like, 9 times out of 10, or even higher than that, 9.99 times out of 10, it isn't a problem, right? Like so you were doing the best you could in that situation too. Maybe it was a higher risk, but it should have worked out just fine.
Yeah. I mean, we all live with risk, and I guess where I land is that I think we should give families enough credit to have more complicated conversations, and we should be talking about this as risk minimization.
That's right.
But the other part of that is, it's not like you deserved Quinn to die less because you did everything right either, so that easily gets lost, right?
Yes, it really does. And I think there's a lot of guilt that parents, especially because, as you mentioned, in a lot of cases, in a lot of locations, the coroners will not call it SIDS if the baby was had any kind of
risk factors. Think about it. If you have a risk factor for SIDS, they will not call it for SIDS. It's an astounding thing.
Yeah.
I'm curious about how you see that play out in terms of parents healing or moving forward. I know you study grieving parents. What are some of the things that you see that are unique to SIDS parents that maybe are different than someone who had a child die of a long-term cancer or something?
Well, I think the question, why did they die? And then because we can't really give a precise answer to why they die, I can't give a precise answer or reassurance to, could I have done anything to have prevented it? Could I have, and that plays out in all sorts of ways. How many people think about calling their pediatrician with a small question and don't? Well, sometimes that baby dies the next day, or all sorts of things. Or you mentioned daycare earlier. So SIDS occurs disproportionately in daycare, and we can speculate about why that is. But think about how hard it is to put your baby in daycare in the first place, and it almost always happens in the first week of daycare. And so, how do you answer all that? And then there is an increased risk for it happening again in your family. We don't like to talk about it so much, but that's another thing that they want to know. Like, are their kids carrying some increased risk? Is their sister who's now pregnant and they're struggling so hard to have a relationship that's generous because they're feeling so badly about what's happened to their baby? But, is it somehow a contagion that's going to go over to that baby? And what's the responsibility there? It's a pretty complicated world.
So do you think it increases anxiety and suffering, like in the years after the loss? You have maybe an increased anxiety, whereas a parent who knew exactly why their child died wouldn't feel as afraid of every single thing in the world, because they could answer those questions of here was the problem.
I've learned not to compare miseries. It's just not,
okay.
You know what I'm saying? but here's what I can tell you. I can tell you, looking at work with parents after this terrible thing has happened, we know that 20 or 30 years later, they'll say every day they're affected by that death, right? So that's profound. I did some research on something called prolonged grief disorder.
I was just about to ask.
Yeah. And, at a year, 60% of the mothers that I questioned, it was a really diverse sample of, hundreds of mothers, met criteria for that. Almost regardless of their background. I think it's a very hard thing to accommodate to. I'm not talking about moving on, or I'm not talking about accepting. I'm just talking about the challenge of integrating something that is so awful and so unknown.
Okay, guys, so we're going to stop there. The rest of this conversation segued into Dr. Goldstein's research in parental bereavement and grief. So if you want to listen to that, please tune in next week. We will release that a week from today. And that also was such a good conversation. So we are really excited to release that one for you guys. But we are going to go ahead and just talk for a couple of minutes about the current recommendations from the American Academy of Pediatrics for reduced SIDS risk. And, we are not experts in any way, shape, or form, and please do your own research, but these are just the things that they recommend.
We're not here to judge parents about what decisions they make. We get it. Sometimes parents are exhausted and they need to do what they make decisions to do. Yeah. And every parent can make a decision about the level of risk that they feel comfortable with. These are just the guidelines that I think you and I, to the best of our abilities, will be following to prevent SIDS. And these are the guidelines that the scientists recommend.
Yes. I think parents are doing the best they can. And we are not here to be oh, you can't do XYZ.
Right.
We're just here to say, these are the things that will lower your risk for SIDS. So I think it's all about risk mitigation here.
Mitigation.
Okay. So I'm going to go ahead and just read through this table of recommendations. I will put the link to this journal article in the description for this episode. So if you want to get more information on any of these, there is a lot of a much more explicit detail about all of these in the article. So feel free to do that. Click the link in the description. So here are the recommendations of what parents and caregivers can and should do to reduce the risk of SIDS. Back to sleep for every sleep, putting the baby on their back to sleep. Use a firm sleep surface. Breastfeeding is recommended. Room sharing with the infant on a separate sleep surface is recommended. So that's room sharing in your room, not bed sharing in your bed, which is not recommended. I think co-sleeping is a term that people can use to mean either, but they very specifically call out the difference between room sharing and bed sharing. Keep soft objects and loose bedding away from the infant's sleep area. Consider offering a pacifier at nap time and bedtime. Avoid smoke exposure during pregnancy and after birth. Avoid alcohol and illicit drug use during pregnancy and after birth. Avoid overheating. Pregnant women should seek and obtain regular prenatal care. Infants should be immunized in accordance with the AAP and CDC recommendations. And then the last thing that it says about, parenting decisions is that there is no evidence to recommend swaddling as a strategy to reduce the risk of SIDS. All right, so those are the recommendations.
We look forward to seeing you guys next Monday.
Bye.
To all of our wonderful new friends, we want to hear from you. Email us at aslongasimlivingpodcast@gmail.com and follow us on Instagram at aslongasimlivingpodcast. We'll get back to you as soon as our grieving brains allow. Yay!